Welcome. We have briefly discussed about scleral buckling procedure in the session on rhegmatogenous retinal detachment, and we'll be discussing this procedure in a little more detail in this session. Scleral buckling is indicated for repairing a rhegmatogenous retinal detachment with a peripheral retinal break. In the majority of patients undergoing scleral buckling, chorioretinal adhesion or retinopexy is also performed, usually by cryotherapy. This is the fundus photograph of a patient who has undergone scleral buckling, and we see here the indentation made by the scleral buckle in the retinal periphery. As we have discussed in the session on rhegmatogenous retinal detachment, rhegmatogenous retinal detachments occur when factors promoting detachment of retina from retinal pigment epithelium overwhelm the factors promoting attachment of retina to retinal pigment epithelium, and scleral buckling helps in reattaching a detached retina by neutralizing or reversing factors which promote retinal detachment, such as by relieving vitreoretinal traction, closing a retinal break, and reducing fluid currents through the retinal break which occur due to saccadic eye movements. Scleral buckles or explants help in repairing rhegmatogenous retinal detachment by indenting the sclera choroid and RPE underneath the retinal break, and this indentation releases vitreoretinal traction on the retinal break and impairs flow of fluid through the retinal break from the vitreous cavity to the subretinal space. A circumferential buckle reduces the diameter of the vitreous base, as seen here in these two sequential diagrams, thus reducing traction induced by the vitreous on the vitreous base and on the retina. Any scleral buckle, by causing invagination of the eye wall at the site of a retinal break, changes the local configuration of the inner surface of the retina from concave to convex. This changes the direction of traction of preretinal membranes, including posterior vitreous cortex, still attached to the retina near the retinal break, from inward, which promotes detachment of the retina, to outward, which promotes reattachment of the retina. And by decreasing the distance between the retina at the site of the retinal break and the retinal pigment epithelium, a scleral buckle also decreases fluid flow through the retinal break from the vitreous cavity to the subretinal space. There are also other factors decreasing fluid flow through the retinal break, such as chorioretinal adhesion or retinopexy created around the retinal break, as we have discussed, and the injection of a gas bubble in the vitreous cavity at the end of the procedure in certain cases of scleral buckling surgery, as we will discuss. And long term, a fibrous capsule forms around the explant, which helps in maintaining position and height of the scleral indentation induced by the explant. Scleral buckles, which come in various forms as seen here in this chart, are made of silicone rubber which is biologically inert. They are trimmed to an appropriate length according to the requirement in a particular case, and although several types of explants are available, three types are commonly used: tired, sponges, and bands. Tiers, as represented by these items in this diagram, are made of solid silicone and are non-compressible. They are usually positioned circumferentially around the eye, and they produce an indentation which is broad and uniform but of a lower height as compared to the indentation produced by sponges. Tiers have a rectangular groove on their outer surface to accommodate a silicone band if required. Sponges, as represented by these items in this diagram, are made up of a silicone material containing air cells and are thus compressible. They are usually positioned radially on the surface of the sclera and produce an indentation which is higher than the indentation produced by tiers, and the indentation produced by a sponge is non-uniform, with the indentation being highest at the center of the sponge. Bands, as represented here in this diagram, are used as circumferential encirclage, often along with a tier, as shown here. The tier supports the retinal breaks, and the band increases the height and the duration of persistence of the indentation created by the tier. For most rhegmatogenous retinal detachments, choice of the explant is less important as compared to its accurate localization with respect to the retinal break. The explant should be positioned such that the posterior edge of all retinal tears are within the indentation, or more specifically, anterior to the posterior margin of the crest of the indentation. The indentation should extend anteriorly to the ora serrata, and the indentation should extend at least 30 degrees beyond the retinal breaks on either side. Sponges, as shown here in these two diagrams, are used for isolated, more posterior and more elevated retinal breaks, and tears, as shown here in these two diagrams, are used for more anterior and or multiple breaks. The width of the tear depends on the variation in distance of the retinal breaks from the ora serrata. Segmental buckle, such as a segmental circumferential tear or a radial sponge, is indicated for single or closely spaced retinal breaks. They support the retinal breaks but do not prevent the future occurrence of retinal breaks in the remaining unsupported areas of the retina. And an encircling circumferential buckle, such as a tear or a band, is indicated for patients with multiple breaks in different quadrants and to support the posterior margin of the vitreous base circumferentially all around in eyes predisposed to future retinal break and retinal detachment, such as those with myopia, aphakia, pseudophakia, and extensive predisposing peripheral retinal degenerations such as lattice. And tears and sponges can be used together if required. Factors determining the internal geometry of the indentation produced by a scleral buckle include shape, material, and orientation of placement of the explant, with high encircling circumferential buckles tending to produce radial retinal folds due to circumferential shortening of globe, as seen here in this diagram. And when one of these retinal folds pass through the retinal break, it can cause fish mouthing of the retinal break, which interferes with closure of the retinal break. Suture tension and transmission of this tension to the explant is important in determining the height of the indentation produced by tears and sponges, and deep scleral bites of at least 4 to 5 mm length provide adequate suture tension, whereas shortening of length of the explant with respect to circumference of the globe is important in determining the height of the indentation produced by an encircling circumferential band, and intraocular pressure can also determine the height of the indentation, with low intraocular pressure increasing the indentation produced by an explant. Scleral buckling can have several effects on the globe, such as changes in axial length due to relative inelasticity of the sclera. A radial sponge has minimal effect on axial length, whereas a segmental circumferential explant, by indenting and invaginating the sclera, decreases the axial length of the globe. An encircling circumferential buckle can either increase the axial length when the explant only indents the sclera, thereby decreasing the coronal circumference, which leads to increase in the axial length, or can decrease the axial length when the explant invaginates the sclera, as a result of which a part of the sagittal circumference of the globe goes into the scleral invagination. Refractive changes induced by scleral buckling can be either changes in spherical equivalent, which may occur due to changes in axial length as described, or shifting of the crystalline lens anteriorly in phakic eyes, or induction of corneal astigmatism, which occurs with radial or segmental circumferential explants. Over several months, the induced change in refractive error regresses as the indentation decreases due to stretch relaxation of the explant and loosening of sutures. Scleral buckling reduces intraocular volume by up to 2 milliliters, which needs to be taken into account to prevent rise in intraocular pressure by removal of adequate amounts of subretinal fluid or aqueous, and to determine the appropriate amount of required expansile gas or medications which need to be injected intravitreally. Encircling circumferential buckles can reduce ocular rigidity, which implies increases in intraocular volume, inducing lesser increase in intraocular pressure due to stretching of the buckle or the sutures. Reduction in ocular rigidity can result in error in measurement of intraocular pressure with devices such as Sheard tonometer, less elevation of intraocular pressure following injection of a certain amount of fluid or gas in the vitreous cavity as compared to a normal eye, and in an eye with raised intraocular pressure, need to remove more intraocular fluid to obtain similar reductions in intraocular pressure as compared to a normal eye. Scleral buckling can reduce ocular blood flow, particularly that in the choroid, and scleral buckling in young children may retard the growth of the eye. Retinopexy or chorioretinal adhesion, which we have discussed in a previous session, is performed in the majority of eyes undergoing scleral buckling. Retinopexy induces necrosis of retinal pigment epithelium and retina around the retinal break, following which proliferation of retinal pigment epithelial cells occurred, leading to chorioretinal adhesion. This adhesion persists indefinitely and prevents redetachment through the same retinal break even when the indentation by the buccal decreases over time. Retinopexy can be done externally either with diathermy, which is presently used very infrequently as it induces burning of the sclera in addition to that of retinal pigment epithelium and retina, or cryotherapy, which is the most common retinopexy technique used in eyes undergoing scleral buckling and which freezes the retinal pigment epithelium and retina with minimal effect on sclera. Retinopexy can also be done internally with laser, which produce burning of the retinal pigment epithelium and retina with no effect on the sclera, but laser requires apposition of retina to the retinal pigment epithelium during application and so is performed several weeks post-operatively following scleral buckling. The final strength of chorioretinal adhesion with these three techniques are similar, although significant partial chorioretinal adhesion occurs earlier with laser within 24 hours as compared to cryotherapy or diathermy, which takes longer. Although the majority of rhegmatogenous retinal detachments with causative retinal breaks in retinal periphery can be repaired with scleral buckling, vitrectomy has become the preferred surgical mode of repairing rhegmatogenous retinal detachments associated with posterior vitreous detachment, but scleral buckling is still preferred over vitrectomy in eyes with rhegmatogenous retinal detachment without posterior vitreous detachment, where posterior vitreous cortex remains adherent to the detached retina and is difficult to detach from the latter with vitrectomy, and these include eyes with retinal dialysis and eyes with rhegmatogenous retinal detachment from atrophic retinal holes, which typically occur in young myopes, and this is very important to remember. Scleral buckling should also be considered in phakic eyes with rhegmatogenous retinal detachment, as vitrectomy has a high risk of inducing cataract in phakic eyes. Indications of encirclage with an encircling circumferential band or tear, including that along with vitrectomy, include early proliferative vitreoretinopathy, multiple retinal breaks with the risk of some of these retinal breaks not being detected and treated, pediatric rhegmatogenous retinal detachment, and as we have mentioned, eyes predisposed to further occurrence of retinal breaks such as those with myopia, aphakia, pseudophakia, and extensive peripheral predisposing lesions. Scleral buckling is not required in areas of retina which are detached but do not have retinal breaks or predisposing lesions, and in areas of retina which are attached even if they have retinal breaks or predisposing lesions, but retinopexy of these lesions are indicated. Contraindications of scleral buckling include proliferative vitreoretinopathy with full thickness retinal folds, which is very important to remember. Significant cataract or vitreous hemorrhage, which interferes with indirect ophthalmoscopic viewing of the retina, posterior retinal breaks, giant retinal tears, scleral thinning, and glaucomatous optic neuropathy. A thorough preoperative ocular examination with slit lamp and indirect ophthalmoscopy with scleral depression is crucial to identify the configuration of the detached zone of retina and all retinal breaks. The locations of identified retinal breaks along with their nearest landmarks and the configuration of the detached retina are recorded in a chart which should be available intraoperatively. If configuration of the detached zone of retina does not match with the identified retinal break or breaks, the chances of having missed a retinal break is high, and this is very important to remember. A thorough preoperative examination also helps in determining the clarity of the ocular media for intraoperative visualization of retinal breaks with indirect ophthalmoscope, in determining the status of the macula, whether the macula is still attached or is already detached, and macula on RRDs, that is RRDs with macula still attached, should be operated urgently to prevent detachment of the macula. In ruling out non-rhegmatogenous retinal detachment, determining the status of posterior vitreous cortex, particularly whether it has detached from the detached zone of the retina, and identifying presence of proliferative vitreoretinopathy and ocular comorbidities which may affect management decisions. We have a video of scleral buckling after we discuss its surgical technique. Local anesthesia in the form of peribulbar or subtenon anesthesia is sufficient for scleral buckling in the majority of patients, but general anesthesia is required in young and uncooperative patients and in reoperations. Standard surgical aseptic precautions are taken and a lateral canthotomy may be required for an eye with a narrow palpebral aperture. Then conjunctival peritomy and tenon capsule dissection is performed to reach the Baird sclera and the rectus muscles. A limbal peritomy is made with radial relaxing incisions at 3 and or 9 o'clock positions. Radial relaxing incisions avoid conjunctival tearing, which is likely to occur due to considerable manipulations involved, and the circumferential extent of the peritomy depends on the size and site of the planned buckle. This group of images show that the conjunctival peritomy is initiated with the radial relaxing incision and is then carried along the limbus, and the extent of the peritomy depends on the size and site of the planned buckle. The anterior tenon gets dissected during conjunctival peritomy as the tenon and the conjunctiva fuse with each other at the limbus, but the posterior tenon, which is also known as the intermuscular septum between adjacent recti, needs to be incised with a pair of blunt-tipped scissors, and the scissors then used for blunt dissection in the subtenon space as shown here in this image till Baird sclera between adjacent recti is exposed. The required rectus muscles, usually 2 to all 4, are then secured by circumferentially sweeping with muscle hooks along the scleral surface and dip to the muscles as shown here in this image, and then passing 2-0 bridle sutures dip to the muscles to secure them. The superior rectus is hooked from its temporal aspect to avoid engaging the superior oblique, and the lateral rectus is similarly hooked from its superior aspect to avoid engaging the inferior oblique as shown here in these two images. The adhesions between the rectus muscles and the tenon fascia or the orbital wall should be minimally interfered with because these fascial connections are important for balanced muscle action, and the bridle sutures can be attached to the surgical drape as and when required. This image shows two bridle sutures securing two rectus muscles. The exposed scleral surface is inspected for areas of scleral thinning which appear darker than normal as shown here in this image, and anomalous vortex veins, and cryotherapy and suturing should be avoided in these areas. During reoperations, strong adhesions are found between the sclera and the conjunctiva which cannot be dissected and need to be cut, and the previous explants are found to be encapsulated by fibrous tissue, and the sclera underneath the explants usually thins. To remove these previous explants, the fibrous capsule needs to be incised superficial to them, but no attempt should be made to detach or remove the portion of the fibrous capsule attached to the sclera underneath. Securing of the rectus muscle should be followed by intraoperative localization of all retinal breaks by indirect ophthalmoscopic visualization of 360 degrees of retinal periphery with scleral depression, and this should be compared with the chart prepared during preoperative assessment, and the site of the retinal break should be marked on the external surface of the sclera, with the location of a small retinal break indicated by a single mark on the sclera corresponding to the posterior edge of the break, but for larger breaks, location of both the anterior and the posterior margins of the break should be marked on the sclera. And it is important to remember that a retinal break in a bullous detachment, as seen here in this image, may be erroneously marked more posteriorly on the sclera than it really is because of parallax error. Following identification of the retinal breaks, retinopexy is performed around the retinal breaks, typically with cryotherapy, for which the cryoprobe is used to indent the sclera at the site of the retinal break, and the cryomachine is then activated with the foot switch. In shallow retinal detachment, the retinal pigment epithelium and the retina freeze almost simultaneously, and the frozen area of the retina appears white as shown here in this clinical photograph, but in bullous retinal detachment, the retinal pigment epithelium freezes first and appears orange as shown here in this clinical photograph before the retina freezes, and in this situation, freezing of the retinal pigment epithelium is considered to be sufficient, or alternatively, cryopexy can be carried out after drainage of the subretinal fluid. A small retinal break needs a single application and appears as a dark lesion within the frozen area, whereas a larger break as seen here in this image, requires multiple freezes all around, minimizing skip areas and areas of overlap, and inadvertent macular freeze, as shown here in this diagram, because of shaft indentation, should be avoided, with this being the correct position of the cryoprobe. Following retinopexy, sutures for securing the explant on the scleral surface are placed with partial thickness scleral mattress sutures made of 5-0 non-absorbable material on spatulated needles. The scleral bites for each mattress suture are oriented parallel to the long axis of the explant and to each other. So the scleral bites are radial for radial explants such as sponges and circumferential for circumferential explants such as TAS. And the scleral bite should pass through 1/2 to 2/3 of the thickness of the sclera. The scleral bites for each mattress suture should be spaced 2 mm wider than the width of the explant, so that enough sclera is used to partially envelop the explant to achieve adequate height of the scleral indentation. Calipers are used to measure the distance between the scleral bites of each mattress suture, and it is important to note that calipers measure scleral chord length between 2 points, which is always less than the scleral arc length between the 2 points along the surface of the sclera on which the explant resides. The posterior extent of each mattress suture should be at least 2 to 3 mm posterior to the scleral localization mark, and the length of each scleral bite of a mattress suture needs to be sufficient to make the mattress suture ideally square in shape. And for circumferential explants, 2 mattress sutures are usually required per quadrant between any 2 adjacent recti, and the 2 arms of the mattress suture over the explant should be parallel to each other. When the spatulated needle passes through the sclera, its flat surface should be parallel to the surface of the sclera. When entering the sclera, the tangent to the tip of the needle should be parallel to the sclera, and after adequate length of the bite is achieved, the needle is rotated to make it exit the sclera. At this stage, the heel of the needle should not penetrate the sclera, which may occur if the needle is over-rotated. The suture knot is secured with sufficient tension to get an adequate indentation of the sclera, and the suture end should be trimmed and the suture positioned posterior to the explant to minimize the risk of conjunctival erosion, which may lead to extrusion of the explant. And if encirclage with a band is indicated, the band is positioned in the groove of the tire, and in the remaining quadrants, the band is fixed to the sclera with sutures placed approximately 12 mm posterior to the limbus. The ends of the band are tied to each other either with sutures or with Watzke sleeve, as shown here in this image. The band should be tightened to create a just visible shallow indentation circumferentially all around, as viewed with an indirect ophthalmoscope. Subretinal fluid drainage, or SRFD, by incising through the sclera and the choroid to allow the subretinal fluid to drain externally, has several benefits. SRFD opposes the retinal break to the RP and choroid over the scleral indentation, thereby facilitating the closure of the retinal break. SRFD helps in reducing intraocular pressure, which increases due to reduction in the volume of the globe induced by the explant, and SRFD also helps in reducing parallax error in localization of break in a bullous rhegmatogenous retinal detachment, as we have discussed. But SRFD is associated with significant complications, as we will be discussing. So there is no consensus regarding when SRFD should be done. SRFD is usually performed in eyes with highly elevated tractional tears, early proliferative vitreoretinopathy, and in eyes with long-standing rhegmatogenous retinal detachment in which the subretinal fluid becomes viscous. SRFD is not required in eyes with retinal dialysis and atrophic retinal holes where there is no vitreoretinal traction at the retinal break. SRFD should be done after placement of the scleral sutures and positioning of the buccal at the planned site of SRFD, but before knots are placed in the scleral sutures. The site of SRFD should be above or below the horizontal recti in the posterior third of the bed of the planned buccal. This closes the sclerostomy of the SRFD site when the buccal is tightened and supports any iatrogenic retinal break or retinal incarceration at the SRFD site. But if the sclerostomy cannot be done in the bed of the planned buccal, the sclerostomy needs to be closed with sutures after drainage. The SRFD site has to be in a meridian where subretinal fluid height is significant, and this should be rechecked immediately before the sclerostomy for SRFD is made. and the 3 and 9 o'clock meridians, along which long ciliary neurovascular bundles pass and vortex veins, must be avoided when selecting the site for SRFD. Two techniques are commonly employed for SRFD, of which the two-step or cut-down technique is more popular. In this technique, a 3 mm incision is made in the sclera, as shown here in this image, by gradually incising the scleral fibers till a knuckle of choroid is exposed in the sclerostomy. This knuckle of choroid is incised with a diathermy needle, as shown here in this intraoperative photograph, and this helps in controlling hemorrhage. The intraocular pressure should be low enough during SRFD with this technique to avoid retinal incarceration at the drainage site, but intraocular pressure should not be allowed to reduce suddenly and significantly, as we will discuss. In the other technique, a needle is used to perforate the sclera and choroid in a single step under indirect ophthalmoscopic or microscopic visualization, and in this technique, the IOP should be maintained on the higher side to reduce the risk of hemorrhage. And it is important to note that during or after SRFD, sudden significant lowering of intraocular pressure must be avoided, which increases the risk of choroidal hemorrhage. To avoid sudden lowering of intraocular pressure during SRFD, scleral suture bites for the explant should be pre-placed and the explant positioned as we have mentioned in preparation for tightening the suture knots immediately after SRFD. Digital pressure can be applied on the globe during SRFD, and after SRFD, the explant suture knots are tightened and air is injected intravitreally if required. If subretinal fluid does not exit adequately from the drain site during SRFD, star folds in the retina or inadequate amounts of subretinal fluid at the drainage site should be excluded, which require a new drainage site. Otherwise, edges of the original sclerostomy can be distracted and gentle digital massage applied on the globe to resume flow through the original drainage site. And in non-drainage procedures, monitoring of intraocular pressure is very important, and intraocular pressure reduction with paracentesis and/or medications are often required. Final ophthalmoscopic examination is then performed to determine the position and height of the buccal with respect to the retinal breaks and to confirm perfusion in the central retinal artery. If the position of the buccal is deemed inadequate with respect to one or more retinal breaks, an additional explant such as a radial sponge needs to be placed. And even if the retinal breaks do not appear to be closed at this stage, the height of the buccal is considered adequate if the contour of the detached retina follows the contour of the buccal. Otherwise, the scleral sutures of the explant need to be tightened or replaced. The optic disc should appear pink with large caliber of the central retinal vessels, and digital pressure should be able to elicit pulsation of central retinal arteries. Paracentesis needs to be done if spontaneous pulsation of the central retinal artery is detected or the disc appears pale with thready appearance of central retinal vessels. And intravitreal gas or air injection is indicated at the end of the procedure for chronic rhegmatogenous retinal detachment with viscous subretinal fluid, or if there is fish mouthing of retinal breaks or significant hypotony after subretinal fluid drainage. Finally, protruding edges of explant should be trimmed and scleral sutures for tires should be rotated so that their knots lie posterior to the tire. All explant should ideally be covered by tenons if required by suturing the tenon, and the conjunctiva closed with 80 vicryl suture. This prevents recession of edge of the peritomy, which creates difficulty during reoperations. And broad-spectrum antibiotic and dexamethasone should be injected in the subconjunctival space where the explants and the sutures lie. Diagrammatic documentation of all explants and sutures should be made and preserved, as this becomes very useful when repeat surgery becomes necessary. We have two video clips. The first one demonstrating the steps from conjunctival peritomy to bridling of the rectus muscles, and the second clip demonstrating a non-drainage procedure from placement of mattress sutures onwards. Complications of scleral buckling include scleral perforation, which can occur during placement of scleral suture bites for the explant and may lead to choroidal subretinal or vitreous hemorrhage, retinal break, retinal detachment, and later endophthalmitis. These are heralded by the appearance of blood, pigments, or fluid at the site of scleral perforation and require indirect ophthalmoscopy for diagnosis. Intraocular hemorrhage and retinal incarceration at the drainage site can also occur during subretinal fluid drainage. This photograph shows occurrence of subretinal hemorrhage, and this image shows occurrence of retinal incarceration during scleral buckling. Iatrogenic retinal breaks require retinopexy and support with an explant. Retinal incarceration at SRFD site appears as a star fold as seen here in this image and should be supported by an explant. After performing retinopexy, if a retinal break is also detected at the site of retinal incarceration, and choroidal hemorrhage needs to be managed as early as possible by increasing IOP, typically with the digital pressure, turning the head of the patient so as to make the site of SRFD most dependent to minimize progression of blood towards the macula, and supporting the suture or SRFD site with an explant. Anterior segment ischemia is a potentially devastating complication which occurs due to high encircling buckles and disinsertion of multiple rectus muscles. Patients with sickle cell disease are at a high risk of anterior segment ischemia following scleral buckling surgery. Clinical features of anterior segment ischemia include pain, corneal edema, anterior chamber flare, and a deep anterior chamber, and initially the intraocular pressure is high because of impaired venous drainage, but later hypotonia occurs due to ciliary body shutdown. This clinical photograph shows a patient developing anterior segment ischemia but after strabismus surgery. Anterior segment ischemia following scleral buckling needs to be intervened urgently by loosening the buckle. As we have discussed earlier in this session, refractive shifts can occur following scleral buckling surgery. Early postoperative diplopia following strabismus surgery is common and usually subsides with time. Persistent diplopia needs to be managed with prisms or botulinum toxin, as strabismus surgery is challenging in this situation and removal of the explant alone may or may not alleviate diplopia. Recurrent retinal detachment can occur due to a retinal break or breaks not being supported adequately by the buckle, either due to the retinal break or part of it lying outside the zone of indentation of the buckle as seen here in this clinical photograph, or inadequate indentation by the buckle itself, and this requires repositioning of the buckle or increasing the height of the buckle or addition of another explant. Recurrent retinal detachment can also occur when a retinal break or breaks remain open over an adequate buccal indentation, which typically occurs due to fish mouthing when the radial retinal fold passes through the retinal break as seen here in this photograph and in this diagram. Fish mouthing can be efficiently managed with intravitreal gas injection. Other signs of failure of scleral buckling surgery include increasing subretinal fluid and development of proliferative vitreoretinopathy, but persistence of subretinal fluid in early post-operative period, particularly in chronic rhegmatogenous retinal detachments and following non-drainage procedures, does not always imply failure of the procedure. Glaucoma following scleral buckling surgery can occur due to steroid administration in steroid responders or due to forward shift of lens iris diaphragm due to obstruction of choroidal venous drainage and the mass effect of the buckle. Forward shift of lens iris diaphragm usually resolves spontaneously with cycloplegics, else division of the encircling band is required. Buccal infection and extrusion following scleral buckling usually occur together several weeks to months following surgery. Risk factors include exposed ends of sutures and explants which erode the conjunctiva. Buccal infection or extrusion presents with ocular inflammation, purulent exudates, and exposure of the explant as seen here in this clinical photograph, and this condition may rarely lead to orbital cellulitis, endophthalmitis, and panophthalmitis. Treatment of buccal infection and extrusion requires removal of the explant because medications alone do not work, as organisms form a biofilm over the explant, and if retinopexy during original surgery was adequate, recurrent retinal detachment following buccal removal is unusual. Preventive measures against buccal infection and extrusion include trimming the protruding ends of the sutures and explants, covering the explants and sutures with tenons, and careful closure of conjunctiva. Anterior migration and intraocular intrusion of encircling bands following scleral buckling surgery have also been described. Occurrence of macular folds is a rare but devastating complication which occurs typically in patients with superior bullous rhegmatogenous retinal detachment following inadequate subretinal fluid drainage or intraocular air injection along with a high buckle. Other complications of scleral buckling surgery include choroidal effusion and cystoid macular edema. Functional visual recovery rates following repair of retinal detachments are not as good as anatomical reattachment rates. In macular detachments, anatomical success rates are very high with excellent visual results, but 10% of patients with macular detachments have a drop in visual acuity following surgery by 2 Nellen lines or more as compared to their preoperative visual acuity due to the occurrence of macular pucker or cystoid macular edema, which are not uncommon sequelae of retinal detachment or its repair. In macula of detachments, anatomical success rates are also high, but visual recovery depends on the duration of macular detachment preoperatively because of photoreceptor degeneration. To recap the salient points, scleral buckling is used to repair rhegmatogenous retinal detachments with peripheral retinal breaks by indenting the sclera under the retinal breaks. This relieves vitreous fraction on the retinal breaks and reduces flow of fluid from the vitreous cavity to the subretinal space through the retinal breaks. In the majority of cases, chorioretinal adhesion or retinopexy is also induced all around each retinal break, most commonly with cryotherapy. 3 types of explants are commonly used. Tires are positioned circumferentially, either in a segment or all around the circumference of the globe. Sponges are typically positioned radially, and bands are used circumferentially all around the circumference of the globe along with the tire to increase the duration of persistence of the indentation by the tire. Sponges are typically used for isolated and or more posterior breaks, and tires are used for anterior and multiple breaks. The posterior edge of retinal break or breaks should lie anterior to the posterior margin of the crest of indentation by the buccal, and the indentation should extend anteriorly to the ora serrata. The internal geometry of the indentation depends on the shape, size, and material of the explant, the tension generated by the sutures and transmitted to the explant, the length of an encircling circumferential explant with respect to the circumference of the globe, and intraocular pressure. The effects of a scleral buckle on the globe include changes in axial length and refractive status, decrease in volume of the globe, which increases intraocular pressure at least temporarily, decrease in ocular blood flow, and decrease in ocular rigidity. Scleral buckling can repair almost all types of rhegmatogenous retinal detachments in the absence of certain contraindications, which include grade C proliferative vitreoretinopathy with full thickness retinal folds, opaque media, posterior retinal breaks, giant retinal tears, scleral thinning, and glaucoma. Although vitrectomy is now often preferred for rhegmatogenous retinal detachments, but in certain situations where the posterior vitreous cortex still remains attached to the detached retina, such as retinal dialysis and rhegmatogenous retinal detachments from atrophic retinal holes, scleral buckling should be preferred over vitrectomy. Scleral buckling should also be preferred in phakic eyes, as vitrectomy almost inevitably leads to development of cataract in phakic eyes. A detailed preoperative examination is crucial to identify the location of all retinal breaks and whether that matches with the configuration of the retinal detachment, clarity of ocular media, status of macula, and the presence of proliferative vitreoretinopathy or any other ocular comorbidity which may affect management decisions. The locations of all retinal breaks and the configuration of the detachment should be drawn in a chart to be used intraoperatively. After anesthesia and standard aseptic precautions, conjunctival peritomy with radial relaxing incisions is made, and tenon dissected till bare sclera is reached and rectus muscles identified. The extent of exposure depends on the type and size of the explant selected. The required rectus muscles are hooked and brittle sutures placed to secure the muscles. The surface of the exposed bare sclera should be inspected to avoid cryotherapy or suturing in areas with scleral thinning or vortex veins. Indirect ophthalmoscopy is performed to mark the location of the retinal breaks on the external surface of the sclera. Cryopexy is performed all around each identified retinal break. The scleral sutures for the explant are placed at the planned location of the explant and the explant position on the sclera. Subretinal fluid drainage is performed if planned, preferably in the bed of the explant, above or below a horizontal rectus muscle and at a site where the amount of subretinal fluid is significant. During SRFD, it is important to maintain IOP with digital pressure if required. Immediately after SRFD, the scleral sutures of the explant are tightened, the suture ends trimmed, and the knots positioned posteriorly. Final ophthalmoscopic examination is then carried out to determine the position and height of the buccal with respect to the retinal breaks and to confirm perfusion in the central retinal vessels at the optic disc. Finally, the conjunctiva is closed carefully. Complications of scleral buckling include scleral perforation during placement of scleral sutures for the explant, which may lead to retinal break and choroidal and/or vitreous hemorrhage, retinal incarceration and choroidal hemorrhage at the SRFD site, anterior segment ischemia, recurrent rhegmatogenous retinal detachment, diplopia, and buccal infection and/or extrusion. The attachment rate following a primary scleral buckling surgery is 90% or more. Following surgery, macula on RRDs and macula of RRDs of a short duration have good visual prognosis, but some patients with macula on RRDs have a postoperative visual acuity less than their preoperative visual acuity because of development of macular pucker, which is a not uncommon sequel of rhegmatogenous retinal detachments. Thank you for listening.